Hi, everyone. My name is Jonathan Marina. I'm an assistant professor at Duke within the Division of Neuromuscular Medicine. And I'm going to be presenting today alongside Carissa Gable, who's a professor of neurology within the Division of Neuromuscular Medicine as well at Duke. And today we're going to be talking about myasthenia gravis and integrating the newer therapies. Please see this slide for further information about how you can obtain credit for today's talk. So to receive your CME/CE certificate, please ensure you attend the entire webinar. Afterwards, complete a brief evaluation and download your certificate using the link provided at the conclusion of the program. And please complete the evaluation by September 21st, 2026. Please see the slide for disclosure of unlabeled use. So anything that we say today is not meant to substitute the medical judgment of a clinician for any one particular patient's medical condition. And see the disclaimer. The opinions are of Dr. Gables and mine. They are not representing the views of Haymarket Medical Education, MedNet, or UCB. Please see the slide for the planner and speaker disclosure policy, stating that we have to list all of our disclosures. And this is the slide containing all of our disclosures. So for today, our learning objectives include summarizing the etiology, classification, pathogenesis, and evaluation of generalized myasthenia gravis, and applying symptomatic, immunosuppressive, immunoglobulin, plasmapheresis, FcRn, and complement system therapies for generalized myasthenia gravis. So we are going to have some questions in today's talk. We will start out the talk with a question. I'll give you some time to answer that. And then after that, I'm going to be going through the first talk, kind of laying the background and talking about the etiology, classification, pathogenesis, and evaluation of generalized myasthenia gravis. We'll have that same question at the end of my talk. And then we'll go on to the next part where Dr. Gable is going to be discussing the older therapies, but also the newer therapies and how to implement them. All right, so we'll start with our first question. A 55-year-old man with refractory AChR positive generalized myasthenia gravis presents to discuss further treatment options. He previously tried FcRn inhibitors, but experienced a significant wearing off effect between doses. He does not wish to pursue complement inhibitors due to concerns about meningococcal infection risk. You therefore discuss B-cell depleting therapies that target CD20 and CD19. What is the mechanistic advantage of targeting CD19? So we'll give you guys some time to read through those and think through the case. Okay, thank you everyone for answering. All right, so now I'm going to get into the first talk. So I'm going to be discussing first the pathophysiology. And the pathophysiology really depends on the type of antibodies present. So I'll be reviewing over the pathophysiology related to AChR antibodies, MuSK antibodies, a relatively newer antibody called LRP4, and then also seronegative myasthenia gravis patients. Now, I'd like to start out, though, by talking about the role of the thymus, because this is really where the pathophysiology begins. And with myasthenia gravis, we see that it's uniquely associated with thymic hyperplasia and thymoma, which is very important in terms of treatment options like thymectomy, which Dr. Gable will be going over more later on. And it's been found that there's been more thymic abnormalities with ectopic germinal centers in AChR positive patients, but not MuSK-MG. And this influences the treatment decisions in these different type of antibody populations as well. Now, it starts with a impaired T cell selection process. There's been found to be lack of thymic medulla and defective autoimmune regulator, or AIR, transcription factor, contributing to the release of autoreactive CD4 positive and CD8 positive T cells. So this T cell subset imbalance, along with cytokine dysregulation, leads to activation of B cells and differentiation into autoreactive B cells and plasma cells. So this slide is summarizing the antibody production. So after we have that loss of immune tolerance, we have these autoreactive B cells being produced. And the B cell lineage proceeds through developmental stages, culminating ultimately in those plasma cells, which you can see on the right, producing antibodies. Now, one particular point of interest is that CD19 is expressed broadly from early B cell development all the way to the terminal plasma cells, whereas CD20 expression only begins at the very late pre-B cell stage and is lost before plasmablast differentiation. So again, this is going to be very important to keep in mind for Dr. Gable's talk about the therapies and how these could work, because our classic treatments like rituximab is going to affect CD20, which is going to be a more limited subset. Whereas there are going to be some newer therapies that we'll talk about that contact CD19, having a more broad spectrum depletion and depleting plasma cells that are already in the system in the marrow and the lymphoid. Whereas, say, for the CD20, they're inhibiting that process of generating new plasma cells and antibody producing cells. However, they're not going to deplete the ones that are already there with those plasma cells towards the right. So, with that background, now I'll get into more of the antibodies. So AChR is the most common antibody, and this is predominantly IgG1 and IgG3 subclasses. And there's three main mechanisms that AChR antibodies can cause disease. So one is activating the complement cascade. So this leads to the formation of what's called the membrane attack complex, or MAC, which damages the postsynaptic membrane and synaptic folds. Another way that it causes disease is by binding and cross-linking of AChRs, leading to endocytosis and degradation of the receptors. It can also impair AChR function by blocking the receptor physically, or more physiologically, preventing the channel opening and further propagation of the signals. So with complement, we have known for a long time that complement has been involved in myasthenia gravis. This is a figure here that I pulled out from Dr. Engel's research. Dr. Engel has been a pioneer in the field. This paper was from 1981, showing the complement activation in myasthenia gravis. So in this figure, in A, it shows ultrastructural localization of C9. And that's going to be the dark components that we're looking at. And that's indicating that MAC, or that membrane attack complex, is present at that spot because the MAC is consisting of C5b to 9. So in A, we can see that the postsynaptic region is relatively well preserved. We can see a lot of those grooves and nice architecture throughout. There is an intense reaction for C9 over short segments of the postsynaptic membrane where the arrowheads are, and sparse debris in the synaptic space. However, in B, we can see that the junctional folds are degenerating on the right, and there's a much more prominent area strongly reacting for C9. On the left side, the junctional folds are somewhat better preserved. There's less C9 positive material there. So now moving on to MuSK pathophysiology. So The main kind of advantage of having Musk is that it leads to AChR clustering. And it uniquely allows the AChR clustering to go right at the top, at the crest of these postsynaptic folds, leading to an advantage of having these vesicles being very close by these receptors, um, and having them all grouped together, leading to a very efficient transmission along the neuromuscular junction. Now, I want to make note that Musk is part of a complex here. So as you can see, LRP4 and agrin are also involved in this complex that's leading to this propagation of signals that lead to the clustering. So Musk antibodies, therefore, are going to disrupt this process. Another note to make is that Musk antibodies are IgG4, and therefore they do not activate complement. LRP4, as I mentioned, is involved in that clustering of the AChRs. They've been found to be IgG1 and IgG2 subclasses, which IgG1 can activate complement, thinking forward about possible treatments that could be related and help with LRP4 disease. Now, outside of those three antibodies, we have seronegative patients or patients who have tested negative for all those antibodies. And the thought has been that these patients may have, in particular, the AChR antibodies, but the titer is too low to be detected, or there's other antibodies that we just haven't discovered yet. So, say of note, there's been some research into agrin. As mentioned, agrin is part of that complex that was related to clustering. It has been found that low affinity IgG antibodies in the seronegative population bind to clustered AChRs on transfected cell surfaces and were of the IgG1 subclass. So they do have the ability to activate complement. But a lot of the research that has gone on has shown a lot of similarities between the seronegative population and AChR population, indicating that these may be similar patients where the antibody is just not high enough to be detected. So now moving on from the pathophysiology into more of the evaluation of MG. I'm going to start out by talking about serologic tests. And then electrophysiologic tests. I'll touch on the ice pack test, as well as CT chest. So for serologic tests, AChR antibodies are present in about 80% of patients. Musk is positive in about 5 to 8%. And then LRP4 antibodies, somewhat controversial in the field right now, so it's somewhat unclear, but has been estimated to be about 1% of patients. Now, with the AChR antibody testing, there are some nuances with this testing that I'm going to go over, as well as with the other tests. I'll go through, certainly a lot of nuances with it. So we want to make sure that we're getting the correct diagnosis first. Certainly, when we want to incorporate these newer therapies, we want to make sure that we have the correct diagnosis first. So with the antibody, if it is a high titer and the modulating is positive, it is very virtually always going to be myasthenia gravis, as long as it's consistent with the clinical picture. A nice study that I included here by Yubing Li and his group at Cleveland Clinic found that a combination of the AChR binding antibody greater than 0.5 with that abnormal modulating antibody is virtually diagnostic, and this was tested through the Mayo lab. However, they did find that low titer antibodies, specifically less than 0.5, as well as with a negative modulating antibody, that these may be false positives. And they found that these false positive patients have other autoimmune disorders, specifically hypothyroidism was one of the more common ones, ALS, and even thymoma, but without having MG. So there's been some nice studies showing that patients with thymomas may produce AChR antibodies, but They don't have any classic symptoms, and they have negative electrophysiologic testing indicating that they don't actually have myasthenia gravis, though. Now, other points to consider is that the antibodies can be negative early on in disease, but become positive later. So you could consider repeating the testing later on. Immunosuppression may also affect the results. So, say if you have someone with rheumatoid arthritis or some other condition, they're receiving immunosuppression, that may affect the results. So you have to keep that in mind. Another point is that the titers do not correlate with disease severity. So there hasn't been really any robust evidence to support the use of kind of following these titers over time. Now, in the cases where they are negative, there's been newer testing that has come out that's called a live cell-based assay that can pick up some of these lower titer AChR antibodies when they're negative, say, on the Mayo test. It's been found to have a higher sensitivity, reported at 83 to 100%, and a specificity of about virtually 100%. So much better than our normal RIPA testing, with a far lower rate of false positives. So it's another utility of this test. So certainly if you have that low titer of the AChR antibody and say the clinical history isn't adding up, you can test for this as well to help kind of sort that out. So if this were negative, then that could be further evidence that that was a false positive. So I ordered this test through Neurocode, and this is the only lab, at least to the best of my knowledge, in the USA that is offering this test commercially. Now, with MuSK antibody testing, there's not as much data on this, but it has been reported to be highly specific, approaching 100% with variable sensitivity. Now, LRP4 antibody testing is a little bit more complicated. There have been studies that have shown that these antibodies are actually more common in ALS, reported about 10% compared to MG, as I mentioned previously, potentially around only 1%. So this finding underscores that the LRP4 antibody positivity alone does not confirm MG, and you really have to take it into context with the clinical situation, your exam findings, and electrophysiologic testing. Now, so those were the antibodies on testing for serologic tests in myasthenia gravis. Now, in addition to that, thyroid function testing is also important. So this should be obtained on all MG patients at the initial visit / the time of diagnosis. Autoimmune thyroid disease or thyroiditis is the most common coexisting autoimmune condition in myasthenia gravis, and certainly has a high association with early onset MG and ocular MG. Now, an interesting point is that thyroid dysfunction can actually exacerbate myasthenic weakness, making identification and treatment very important for optimal MG management. And it can also be a mimic of ocular MG, or what's called thyroid eye disease, or TED. So some differences that can come out, though, is that TED can have proptosis, can have eyelid retraction, which may lead to the appearance of a pseudotosis, so you don't want to have that trip you up. It has more of a fixed double vision that's not fluctuating as we see in MG. There can be conjunctival injection and eye pain. In terms of testing, you can send for thyrotropin receptor antibodies, and MRI can also be helpful to differentiate. So the MRI in TED may show some increased edema and increased size of the extraocular muscles, specifically medial rectus and inferior rectus. And there could even be enhancement showing more active disease. Whereas in myasthenia gravis, the MRI of the extraocular muscles tends to be normal. However, in very long-standing disease, you can see atrophy. which would be a poor prognosis in terms of recovery or treatment success at that time. One other thing too, kind of on that note, is that myasthenia gravis can classically cause an exotropia, whereas in thyroid eye disease, that is very rare, tends to cause more of an esotropia due to that edema occurring in the medial rectus, along with fibrosis. It's more pulling that eye inward rather than a weakness, like we see in myasthenia gravis. So now moving on to electrophysiologic tests. I'm going to talk about repetitive nerve stimulation and single fiber EMG. So for repetitive nerve stimulation, we use low frequency, which is 2 to 3 hertz for MG testing. Now, if you're testing distal muscles, they should be warmed and maintained at 34 to 37 degrees Celsius. I tend not to have as much problem with temperature on the more proximal muscles and facial muscles, which are the highest yield for testing. In general, if you do have a weak muscle, that's what should be tested first. But if you can't, and particularly test that muscle, you want to go for facial and proximal muscles. It is abnormal if there is a greater than or equal to 10% decrease or decrement in the compound muscle action potential amplitude. The largest amplitude decrement is usually between the first and second CMAP, with the nadir typically at the fourth or fifth. So we can see here on the right, the largest decrease from the first to second, the nadir at the fourth. And at the fourth here, what's occurring is we have mobilization of secondary acetylcholine stores. So that's going to replenish and lead to a slight improvement in what's called a U shape in myasthenia gravis. So this is different than what we see in some other conditions like Lambert-Eaton myasthenic syndrome. It's been shown to have more of a progressive decremental pattern. Now, the interpretation of RNS is very important because there can be lots of different things that can lead to an inaccurately interpreted result. So first, I want to talk about how the decremental response on rep-stim is not just exclusive to MG. So this can occur in other disorders like motor neuron disease and myotonic disorders. So again, you have to take it into the clinical context and with your physical exam. Other things to keep in mind is that treatments such as acetylcholinesterase inhibitors or methadone can improve symptoms and also improve rep-stim results. So you can get a false negative. So those should be held at least 12 hours prior. You can frequently get normal results in ocular MG. So it's of higher yield if you do have a purely ocular or very mild ocular to go straight to single fiber EMG testing if you have that available. I made mention about warming the patient. So if they are cool, especially on that distal muscle like an ADM, there may be no decrement. And this kind of goes along with the other things that we see in myasthenia gravis being temperature dependent, where cooling improves symptoms and heat is going to worsen. So, classically, myasthenia gravis patients may have worse symptoms in the summer if they're out on a very hot day or take a very hot shower. And then from the cooling aspect, we have things like I'll get into in a little bit here, like the ice pack test that can help improve symptoms. And what that's doing is it's inhibiting acetylcholinesterase. So you're having more acetylcholine in that synapse to be able to lead to more transmission. One other point that I'd like to make is movement artifact can come up with rep-stim. So in the picture here on the right, you can see at the bottom, the movement artifact is a kind of random assortment of CMAP amplitudes that are presenting here. And this can lead to an inappropriate interpretation of decrement. So say, for example, if the fourth one just happens to be very low, and the EMG machine is going to record from the first to the fourth and say report it as say, just for example, 20% decrement, that could be interpreted as abnormal when in reality it was just randomly like that due to the movement artifact. Single fiber EMG is the most sensitive test that we have for EMG. So to the right, I included a figure here showing that in generalized MG, if you do single fiber EMG of multiple muscles, you can get the sensitivity up to 99%. And very similar in ocular disease, getting up to 97%. We can see that the AChR antibody, as I mentioned, coming in at 80% for generalized. It's going to be lower for ocular here, at least with this study, they found 55% were positive. And to the left of that, you can see how rep-stim was only 48%. So did even worse than the AChR antibodies. And, kind of goes to that point where if you have a purely ocular patient, maybe better just to go straight to single fiber EMG. So the degree of abnormal jitter correlates with disease severity. So this can be very helpful in many different cases. So you could consider doing serial jitter studies over time and using that to help determine if the actual disease status is worsening or not. So sometimes things can come up, say like a lumbar radiculopathy causing weakness in the legs, and the person or the team may not know if this weakness is due to myasthenia gravis or from another cause. You can do this testing to see where the severity is. Is it worsening or has it improved on treatment? Now, just like with rep-stim, abnormal results can be seen in other conditions. So in particular, ALS can have abnormal single fiber EMG results with increased jitter. Can also show increased fiber density, though, too, which is a marker of reinnervation. So myasthenia gravis would not have increased fiber density. And then, of course, the EMG changes with active and chronic reinnervation on the EMG that you see in ALS that you certainly are not going to see in myasthenia gravis. So again, in isolation, can be seen, abnormal results can be seen in other conditions, but you have to take it all together. Now, in particular, one condition called CPEO, which is chronic progressive external ophthalmoplegia, a mitochondrial myopathy affecting abnormal movements of the eyes and ptosis. You cannot distinguish from myasthenia gravis based on single fiber EMG alone. So studies in the past have shown that the amount of jitter is very similar between the two disorders. However, if you do have a generalized myasthenia gravis, that the jitter in those patients should be more than what you would see compared to mitochondrial myopathy. So in this slide, I've included an algorithm that I made in terms of breaking down kind of the different testing and what to consider. So with myasthenia gravis, if it is a limb axial predominant pattern of weakness, repetitive nerve stimulation, as I mentioned, testing a clinically weak muscle if possible. If not, the facial and proximal muscles are going to be the highest yield. If there's poor tolerability, so say if you're getting a lot of movement artifact, you could consider doing ADM. And then if negative, going on to single fiber EMG if you have high clinical suspicion. And EMG is also important in these patients to rule out mimickers such as myopathy and motor neuron disease. And the nerve conduction studies are important as well, as a mimicker could be Lambert-Eaton myasthenic syndrome, which would have low CMAP amplitudes, whereas they would be normal in myasthenia gravis. If it's a bulbar predominant weakness, again, you can start with repetitive nerve stimulation, doing facial proximal muscles. And Conius, in particular, has some evidence behind this being studied in bulbar disease, or again, doing ADM if negative. And again, if negative, move into single fiber. In terms of the bulbar predominant weakness, mimickers that you want to keep in mind, again, motor neuron disease, and also oculopharyngeal muscular dystrophy. So this is in autosomal dominant muscular dystrophy that can present with more of a gradual onset of ocular disease and dysphagia. Um, you can also see rimmed vacuoles on the muscle biopsy, and of course, would not respond to immunosuppressants. If you ever do have a patient who's not responding to treatment, certainly consider other etiologies. Now, for pure ocular weakness, as mentioned, you could go straight to single fiber, doing frontalis and or orbicularis oculi. If it's not available, repetitive nerve stimulation is still reasonable, doing facial muscles, and then if negative, considering proximal. And then EMG, as I mentioned, ruling out myopathic conditions such as CPEO. And in general, CPEO is going to have more of a symmetric ptosis and can have a very severe limitation in extraocular movements. It's not going to have the fluctuation that you see in myasthenia gravis. And also this, in a similar manner for OPMD, you're not going to see that fluctuating nature that you see in myasthenia gravis. So now moving on to the ice pack test. So in the picture here, you can see ptosis of the left eyelid. And then ice was applied for 2 to 5 minutes, and you can see improvement. And this has been shown to have a high specificity and sensitivity for myasthenic ptosis. Certainly, if you have ice packs in the clinic, you can use those. If you don't have them available, another thing that I've done is using gloves, and you can put ice in the glove and then just tie the open end to be able to use that. Other testing that we want to keep in mind is obtaining a CT of the chest. So this should be obtained in all patients to rule out thymoma. Thymoma is present in about 10 to 15% of AChR positive MG patients. It's very rare in MuSK positive MG or seronegative MG. And then another note that I briefly brought up earlier is that patients with thymoma detected for other reasons can have positive AChR antibodies but not develop MG. But one study did find that about 30% of patients can end up developing MG. So in conclusion, no test is perfect. There's many nuances in the testing of MG. Certainly, abnormal testing just alone, it doesn't always mean the patient has MG. Normal testing doesn't always mean the patient does not have an MG. So it's unfortunately not 100% or as easy as we'd like it to be. So you really, as I was mentioning, you have to take it into context with the clinical history and the physical examination before coming to a conclusion about the diagnosis of MG. Now, say that you have made an accurate diagnosis of MG. There's some scoring systems that I want to go over. And these are important for the newer therapies because once you submit to insurance, insurance is going to want to look at these scores for approval. So with these, it's broken down into 5 classes, 1 being ocular and 5 being defined as intubation. And then in the middle, we have class 2, 3, and 4, which is based off of how severe the weakness is. It is somewhat subjective, but broken down from mild, moderate, and severe. And then in A, for each category, it's going to be predominantly affecting the limbs or axial muscles. And then B is going to be predominantly affecting the bulbar muscles. So with the newer therapies, at this time, they're all approved for class 2 or above. There is a study that has been ongoing for ocular patients that Dr. Gable will get into that is likely going to be approved soon, but at least at this time, it's all class 2 and above. And then the other score that I would recommend doing on all patients with myasthenia gravis and at each visit is the MG-ADL score. So the MG-ADL score involves these 8 different categories of symptoms. And just a couple of notes that I want to make about this is that these symptoms are symptoms that the patient has had in the past 7 days. So, if they had constant slurring a month ago, but say within the past week or two, it's just been intermittent, you would just count it as intermittent. This is also with the patient on treatment. So I sometimes get asked that. So say, if the patient is taking Mestinon and that has improved their talking to being only intermittent, but they know if I don't have my doses, it can become constant. Within the past week, if it's always been intermittent because they've been on their medication, then you would count it as intermittent. And then one other note too on this is that these should come from the patient, not from anyone else, not from a family member or a spouse. So I've had on a couple of occasions where I walk in the room and the family members filling this out. That's certainly not what we want. We want this to be coming from the patient. And that can make an impact because, say for eyelid drooping, they may not notice it at all or rarely notice it, but a family member may notice it more. So that could affect the scoring. So you want it to be truly from the patient on this. All right, and that's all I have. Thank you very much for your attention. So we're going to be going into that same question. So again, this was the 55-year-old man with refractory AChR positive generalized MG. He had wearing off effect from FcRn, didn't want to do complement inhibitors, so you're discussing B cell depletion. And the main question was going after what's the mechanistic advantage of targeting CD19?
Okay, so thanks for that overview, John. We're going to get into some of the treatment options, a kind of broad overview of so many treatments available now. So exciting. So first with a pretest question. So 35-year-old woman with acetylcholine receptor positive myasthenia has ocular symptoms only of diplopia and rhitosis. So new diagnosis, not a long duration of disease. Started taking 60 milligrams 4 times a day of pyristigmine per treatment. Has had some response and improvement, but then symptoms are still ongoing, still disruptive to day-to-day life, making reading, working, driving very difficult. And so she's most frustrated with intermittent, fatigable daily diplopia. So at this point, what would be the best option for treatment at this stage? Just bumping up that dose of pyridostigmine, bringing in eculizumab, nipocalimab, prednisone, or inebilizumab. And we'll give you a few minutes, or it's half a minute or so to answer that, and then we'll circle back around at the end, see what you think. Okay, interesting. All right, so we'll keep going here. Let's see here, click on my slides. All right, so this whole talk is about integrating, the newer therapies, the FcRn and complement inhibitors, and we're going to do a little bit of context too for the other therapies as well. So just an overview. We'll talk a little bit about the kind of context of the newer treatments that are some of which are non-targeted, as well as thymectomy, and then also target-specific immunotherapy for specifically the FDA-approved medications and also ongoing clinical trials. So the big picture here is goals of therapy. So what are our goals of therapy? I think first and foremost is do no harm, right? And then from there, you're trying to achieve minimal manifestation of disease. That is the goal in myasthenia, or even remission. But at the very least, minimal manifestations, and then improving quality of life, minimizing side effects. And that therapy can vary for each patient. And that's going to be the important things to consider when you're considering all of these different options that we have available now. What's the degree of severity of disease? What will this require to get under good control while minimizing the risks and maximizing the benefits, targeting the symptoms that the patients complain about most, which is why those outcome measures like ADL, which is typically the primary outcome measure for most clinical trials, and the other ones that we use kind of routinely in clinic, just putting in the dot phrase and just just kind of monitoring patients. So I find very helpful to have the MG composite, the QOL, and then the MMT, which is basically your clinical exam, to kind of monitor that response to treatment and helps you decide how to adjust and pick those treatments. Considering the comorbidities of the patients and also cost is definitely a consideration as well. So, generally speaking, it's a rare disease still, 12 and 100,000. A quarter of patients still have residual symptoms or are refractory. And that's where a lot of these newer treatments, I tend to use them. Keeping in mind too that the current sort of maintenance immunotherapies have immune suppressive effects. So that has to be weighed against the risk versus benefit for every patient. Just an overview, it's kind of remarkable with time how this used to be myasthenia gravis, which was very gravis, and it had a high rate of mortality a little while ago. But as you see, as kind of mechanical sort of interventions and then treatments where steroids were introduced in 1966, and then the treatments from there on, we had a remarkable improvement in mortality, and now our goals are more minimal manifestation of disease and control of symptoms, so people don't have that interfere with their day-to-day life. And so it's kind of amazing that FDA approval for therapies, you have pyridostigmine in 1955, and then from then, just literally nothing was FDA approved until 2017, and then there's just been a remarkable explosion of therapies, and trying to figure out the algorithm to use those is a little bit beyond the scope, but we'll talk a little bit about integration in this discussion. And so really symptomatic treatment remains pyridostigmine and the oral therapies. And then beyond that, there's we're using immunosuppressive treatments, and the oral steroid-sparing agents has traditionally been kind of maintenance treatment. If beyond prednisone, that's not, you need something more for a steroid-sparing agent for control. Typically, azathioprine and mycophenolate are the first go-tos, kind of limited toxicities compared to the others that require more monitoring, like tacrolimus and cyclosporin. Thymectomy gives you long-term remission based on the thymectomy trial we'll talk a little bit about. And that's really long-term. So it's not emergent. It's not something, although shorter duration of disease has better outcomes and antibody-positive disease has better outcomes for getting thymectomy earlier, even if there isn't a thymoma, and antibody positivity, of course. But I think, that's something that sometimes comes up as something you want to do when, some people want to do that right away. You really want to make sure that MG is under control first, because this is long-term data over 3 years, either reduction in requirements for medication or remission are possible with the thymectomy. And then IVIG and plasma exchange really more for crisis. So I just want to highlight that there are 2 studies looking at the steroid-sparing drugs of azathioprine and mycophenolate, the Duke Registry study that took a look back over a couple of years of patients and found that within 2 years, and definitely even more within 5 years, there was a minimal manifestation of disease between 75 and 84% of patients. And then the PROMISE MG study also showed similar good results with those, which is why we use those medications for steroid-sparing agents in their oral therapies. Of course, there are risks associated with them as well. You have to weigh those, but just to know that that's why those led to sort of consensus guideline continued recommendations for those medications. With respect to thymectomy, there was the MGTX trial from 2016 and a 2-year extension trial, and that showed primarily the most benefit is for antibody-positive patients up to age 65, in patients kind of with a shorter duration of disease. So that's still a consensus guideline recommendation. And here you can see a couple graphs looking at QMG score and prednisone dose, and both of which show that those patients that had thymectomy plus prednisone were on lower doses of prednisone and had lower QMG scores, so better outcomes there. For crisis or MG exacerbation, there have been some studies, we know it's effective too in practice. And then one study showed some evidence of efficacy of IVIG versus placebo. There were 2 studies looking at IVIG versus Plex. One showed no difference between the dosing of IVIG, and one showed no difference between IVIG and oral methylprednisolone. But primarily, we're using IVIG or plasma exchange in a crisis situation. So it's pretty comparable. And either treatment can be offered depending on the resources. So So just with that context, we'll kind of jump into the novel targets because there's so many to cover. And I'll look at the highlights of the trials and kind of try to point out, I think, some things to keep an eye out for: route of administration of these medications, which plays a role in choice, and also target as well, and considering interactions between some of them, or what some medications are, also going through the FcRn, or Fc receptor, like ravulizumab, in addition to the antagonists for FCs that are available. So we'll talk about complement inhibition, the neonatal Fc receptor antagonist medications, B cell and plasma cell targeting therapies, chemokine and cytokine targeting therapies are still in trials, and some other trial medications with CAR T. So I put together this chart just to kind of organize things. Primarily the ones that are asterisks are the ones that are not yet FDA approved or still in clinical trials, some of which have had positive results and sort of interim press releases and things we can talk about. But we'll start with the complement cascade, just an overview for reminding you there's the three pathways that end to the convergence in C5, which then leads the terminal complex, membrane attack complex, which leads the kind of destructive part of the complement cascade. And so the vast majority of medications in complement inhibitor development for MG has been targeting C5. And then we have one that's in clinical trials, iptacopan, which is a target factor B in the alternative pathway. So to give an overview, like I said, keeping in mind route of administration, keeping in mind kind of frequency of treatments, and then any kind of side effect profiles that will help you guide you with choice of treatment. And so eculizumab was the first complement inhibitor approved for MG. This was based on the REGAIN study. This is a recombinant humanized monoclonal antibody that inhibits C5 activation. So the vast majority of trials have been discussed. As you note, the ADL is the score that's the primary outcome measure for most studies. And so typically they're looking for a 6 or more for enrollment or inclusion into the trial. And that's kind of mild to moderately affected patients. So we classifications of the MGFA score that he went over. And most of the time the trials are generally like between 24 and 26 weeks for treatment to really look at change over time. So this trial was looking at refractory acetylcholine receptor positive patients. So that's another thing to keep in mind with these different drugs, is what was the indication for the trial, because that is what leads to the FDA label approval for those specific patients. So this was approved for acetylcholine receptor positive patients. And they were refractory, defined by either 2 immunosuppressive therapies they tried, or 1 immunosuppressive therapy and chronic IVIG plasma exchange use, which sometimes is required. Interestingly, based on their first analysis, because of what they did with their choice, it didn't meet their primary endpoint. They did a worst rank analysis. They went back to do a responder repeated measures analysis, and of course, other open label studies that did show efficacy, which led to the approval. And I'm sure many of you have used it in practice since it's been available for a little while. So this is IV dosing every 2 weeks. So then from then on, there was ravulizumab. So this was developed to allow a little less frequent dosing. So instead of every 2 weeks IV, it's every 8 weeks. And just to keep in mind, this is a monoclonal antibody that does inhibit C5, but it goes through the FcRn pathway for recycling in order to extend that half-life. So then that you have to account for. If you're also dosing with IVIG, immunoglobulins also get recycled through the same pathway. Or if you're deciding to choose to use some other medication that also antagonizes the FcRn pathway. So just keeping that in mind. So this was a CHAMPION study. It was just a phase 3 study, 26 weeks. They looked at MGA ADL scores for their primary outcome measures. Generally speaking, you want to see that both the primary outcome measures and the other secondary outcome measures all sort of go in the same direction. That would be sort of ideal goal for efficacy, keeping that in mind for other trials as they kind of develop more drugs and come out. But this showed efficacy and significant improvement. And so that was led to the approval for acetylcholine receptor positive patients in 2022. There was an open label extension study that was done up to 60 weeks, and that was really to kind of reassure and can evaluate for long-term safety. I did have 160 patients and no meningococcal infections were reported. And as I'm sure you're aware, the complement inhibition can lead to a risk for meningococcal infections, which we usually use vaccinations to prevent those infections, or antibiotics initially if we have to start them quickly. And then also the vaccination schedule we'll talk a little bit about, but that was a good news that over the long term there were no infections. Then in 2023, there was this complement inhibitor that was improved. So this was based on the RAISE study. It's a little bit of a different of a molecule. It's a macrocyclic peptide C5 inhibitor. This was targeting non-refractory as well as refractory patients, also generalized acetylcholine receptor positive. So this the issue mainly it showed all great things with it. They only looked at a change from baseline to week 12 and showed very statistically significant reductions in all the measures and improvements. So this is daily sub-Q dosing. This was approved in 2023. Jafrulimab is not yet approved. There were some preliminary good results. This is an anti-C5 bispecific nano antibody in the PREVAIL study. So this is a sub-Q weight-based dose weekly, and it targets acetylcholine receptor positive MG patients. So they printed in some press release data showing initial good results and significant ADL reductions at week 26, but we'll see what happens with that. This is an interesting medication. So posolizumab and cemdisiran. So two different kind of targets. So one's a C5 complement inhibitor antibody, and one's actually an siRNA that suppresses C5 synthesis. So this was a phase 3 study of the NIMBLE trial. So this was targeting acetylcholine receptor positive and LRP positive MG patients. So there were a couple different arms with this trial. One was just cemdisiran by itself, 600 milligrams every 12 weeks. And then one was what they call ChemDepose, which is combo, which 200 and 200 milligrams of IV and then sub-Q, posolizumab plus cemdisiran. Interestingly, their results preliminarily have shown that cemdisiran monotherapy has a little bit of better reduction in the kind of expected measures than, or the typical measures than the combination, although the combination also shows statistical significance. So they'll be continuing that trial and analysis. Lastly, the last kind of in development complement inhibitor is an oral complement inhibitor. So that targets the alternative pathway. So this is an ongoing trial currently recruiting, targeting acetylcholine receptor positive patients with generalized MG. So that would be remarkable if that shows efficacy. We'll see as it's ongoing because that's an oral therapy. And just briefly, there is a risk, and there's a REMS program and they have to enroll when you prescribe these medications for monitoring these patients, and vaccinations need to be kept up with the same, covering all the serogroups, whatever vaccine combination you decide to choose, and then remembering to also keep up with those boosters to prevent infection. So we'll switch over to FcRn inhibition. Why is this a target? In brief, this is a target because it is the way that IgGs are recycled. And so, and this is a normal pathway also that maternal IgGs pass over to the fetus for immunity as well. And so this figure highlights the normal mechanism at the top, where you have immunoglobulins that bind to that receptor and then get recycled, and anything that's not bound goes to lysosomal degradation. And so in the bottom here, the little purple and the fragments, those are representative of FcRn blockers or antagonists. And so those bind, and as you can see, if those are bound and recycled, then all the other kind of pathogenic IgGs are being going to lysosomal degradation. So we have efgartigimod, where there's an IV weekly for 4 weeks with variable kind of 6 to 7 week cycle breaks, generally speaking. And then there's a sub-Q weekly available for 4 weeks with also variable cycle breaks. Rosenelixizumab, which is a sub-Q weekly for 6 weeks with variable cycle breaks in between, and still in clinical trials. We have and also more recently approved nipocalimab, which is IV Q2 weeks phase from the Vivacity trial, and batoclimab, which is sub-Q weekly weekly, that later they switched over to a different molecule, 1402, which is current trials. So a little bit about the ADAPT study. This was from how efgartigimod got approved, because this is a little bit different. It's an IgG fragment that binds. And so this is the IV formulation. I just want to highlight here that, interestingly, 71% of patients were responders and 37% responded in cycle 2, having not responded in cycle 1. So I would say keep that in mind when you're treating patients, because sometimes you need to treat for a little longer to catch those people that might need a couple cycles to improve. And so this is for once weekly for every 4 weeks, no sooner than 50 days after the start of the prior treatment cycle. The sub-Q availability is based on the addition of hyaluronidase. So this is an enzyme that allows for subcutaneous absorption. It's naturally occurring in the body. You inject that, and then that opens up the space a little bit for temporarily so that you can inject a higher volume. And so you can also have healthcare provider administered and self-administration, which are both important. I'll say a little bit about the 2 trials for seronegative patients, because when something gets FDA approved for seropositive patients, it's really hard to get prescribed those things off label, and for patients who are seronegative who could benefit. And so we'll see what happens with these 2 trials, but this is looking at both. There's one looking at generalized MG and one looking at ocular only for seronegative MG. And so there were some initial results stating preliminarily that the Oculus trial, or ocular only MG, did have a good outcome with treatment with efgartigimod. So we'll see where those trials go and availability for those patients. Potentially. And then microNG was the study for rozanolizumab. That is the weekly sub-Q infusion, and this is approved for acetylcholine receptor positive and MuSK positive patients as of 2023. Nipocalimab, this was approved actually in April of 2025. And so this ultimately is an IV medication every 2 weeks. So that's another option, a monoclonal antibody. So great results with that. Batoclimab was initially a molecule that was being developed in MG, a couple different doses, looking at ADL as outcome. They had some good initial results. Unfortunately, their side effects were a lot of peripheral edema due to the molecule affecting the albumin binding. And so they reformulated that molecule into a molecule called Immunobot 1402. And so that's an ongoing trial for phase 3 to kind of reassess that target there. And then we have the B cell inhibitors. So we talked a little bit about rituximab. And so I'm sure you're familiar with using this. There have been a number of kind of mixed trials. There was one in 2017, which is a systemic review that looked at both MG, acetylcholine receptor positive, and MuSK patients, and to show a benefit of MuSK for rituximab. The BMG study was a little bit different. So that was mild to moderate acetylcholine receptor positive patients. The outcome was looking for a reduction in steroid use, but it didn't really show that. So then it brought up for discussion like, oh, does this really work in these patients? But then more recently, there was a 2021 systemic review looking at refractory MG patients, and that looked at a really broad number of studies and patients, and ultimately concluded it probably does work for those patients, for some subset of population of those patients, and for MuSK. And so that's what led to the consensus guidelines for management to say that rituximab can be used early on for MuSK positive patients. And then the efficacy of that for refractory patients is a little uncertain, but is an option. So that's something to consider. And there was also, in brief, the RhinoMax study. So this was a Swedish study that was done looking at a low dose of rituximab early on in disease, and looking for efficacy there. And they did show that there was a reduction in, it did show efficacy, but I think in some measures, but not all measures. So it's just something to kind of still consider with caution. Sometimes there's later age of onset disease. There's some retrospective studies showing older people respond really well to it. So it's something to kind of keep in a refractory area, I think, based on what the guidelines still recommend. And there will be an update in guidelines shortly, so keep an eye out for that. And then inebilizumab is the most recent medication that's been approved in December of 2025. So this is what Dr. Moreno was talking about with a target of an anti-CD19 monoclonal antibody that targets the pre-B cells, mature B cells, and some plasmablasts. So this was the MINT study. This actually targeted acetylcholine receptor positive and MuSK positive patients. So you get an infusion of IV 2 weeks apart, and then the maintenance dosing is every 6 months. So that for some patients could be very convenient. It did show efficacy in the expected outcome measures. And getting into the last couple areas of targets, so chemokine, cytokine targets. So satralizumab, it was a monoclonal antibody targeting the IL-6 receptor in acetylcholine receptor positive MuSK and LRP4 in the LUMINES trial. So it did show some small statistically significant areas. So we'll see what comes from that. And then tocilizumab is the other one that's still ongoing in trials. It's a phase 2 study that's looking at these targets of also IL-6. There's been some open label and case series published as noted there. This is targeting acetylcholine receptor positive patients, and this is an IV infusion every 4 weeks. And then we have CAR T lastly. So CAR T is an interesting approach. So this is basically designing T cells to be administered to the patient that will then seek out the B cells that are sort of pathologic with certain antigen expression and try to eliminate those and ideally improving symptoms for a longer term. So there was the DISCART study, which is a phase 1b/2a study where 14 patients were enrolled with generalized MG. And it didn't show initially any toxicity that was of concern. And then at 9 months of follow-up, there were some meaningful decreases from baseline and all the kind of outcome measures. So improvement was seen in everywhere, the other outcome measures. And then there's a phase 2b study ongoing to see what the results of that will be. And then there's also a CAR T phase 1 study for MuSK patients that we haven't gotten all the results from, but we'll see what that shows. So I would say kind of staying in with the limits of time, it's hard to cover all of these in great detail, but hopefully that helps the little overview of just like a snapshot of what's available now and what's coming down the pipeline. There's a lot more too in development. I think the things to consider as we have this influx of so many treatment options is really consider the patient, look at the patient, see how severe the symptoms are. What are the other comorbidities of those patients that might preclude the use of other certain targets? Considering the route of administration, and the IV versus sub-Q, the frequency or the treatment burden of those treatments, the pathway to administration. Some patients don't feel comfortable giving injections to themselves. Some people prefer that. So that's kind of a patient preference for the most part issue, or also patients for the most part are usually pretty compliant, but helps with compliance too and documentation of treatments. And then, there are potentials to change the treatment paradigms. Treatment algorithms for MG kind of are shifting. And so you could consider someone getting, antibiotics and a complement inhibitor to bridge for other medications that you might try, or before thymectomy, or using an FcRn blocker as an initial treatment potentially. I think just considering cost and access to medications is important. As well as dosing frequency. So with that, I'll wrap up. And with this clinical vignette, we'll go back to the 35-year-old woman who, with acetylcholine receptor positive MG, who has ocular symptoms only, with a new diagnosis, where pyridostigmine seems to be having some effect, but still has a lot of breakthrough symptoms that are very disruptive to her life. And we'll see what you feel like the best option is here for treatment at this stage. Okay, interesting. I would actually choose prednisone in this case because it's just ocular symptoms and the risk of like a low dose prednisone, in addition to, I didn't talk a lot about prednisone because that's kind of more historical use medication in this this talk is more about of the novel therapies. But don't forget about prednisone. It's very effective. It works really well. And for someone who has some response to pyridostigmine, I think she's at the maximum dose of it. So anyone who needs more than 60 milligrams 4 times a day of pyridostigmine should be on some immune suppressive therapy from that point, because that's just a symptomatic treatment. It's not altering the course of the disease, and the disease still seems to be a little bit more aggressive with breakthrough symptoms. And there are patients who are mildly affected that can only use pyridostigmine for symptomatic treatment and get by with that. This patient could not. So then the next step would be just to start prednisone and a low dose, and to see what the effects would that be before escalating therapy further. There are patients that have resistant ocular symptoms. And that's where you might start incorporating the use of other kind of novel therapies for patients who really have a lot of disruption to their life with those ocular symptoms. So with that, I will stop. I will move on to the next, which is our Q&A session. I think one of the questions maybe Dr. Marino wants to answered pretty effectively throughout the talk, but it was put in early on, which was, how is MG diagnosed and treated in the community medical practice compared to tertiary medical centers?
Yeah, from a diagnosis standpoint, one of the main differences is going to be access to single fiber EMG or electrophysiologic testing. So it is a very unique procedure that's really not even done at all tertiary medical centers. Certainly feel free if you're in the community, if you have a patient that you're not sure of the diagnosis, or if it's seronegative, certainly feel free to refer those patients to a tertiary center to receive electrophysiologic testing like single fiber EMG. Really, I think with all seronegative patients, they really should have some abnormal electrophysiologic testing done to confirm the diagnosis.
Yeah. Looks like we don't have many other questions here. Any other questions for the group before we close today? I think yeah, all these treatments are so great to have as options for patients, especially for seronegative patients that we struggle with sometimes. But okay, well, if there's no other questions, I think we'll close. Thank you much for attending, and hopefully you found this all to be very useful.